Now I have the pleasure to introduce our keynote speaker, Dr. Joan Benson. And I first really want to thank her because, like a true global health person, she just arrived from Geneva last night. So we're very lucky that she could make it and none of her flights were delayed. You have her bio in the program, so I'm not going to read it, but I just wanted to summarize a few key points from it that I find are especially important. So as you'll see, Dr. Benson has received formal higher education in both the Global South and the Global North, that being Nigeria and the US. She has both clinical and public health degrees. Professionally, she has excelled across multiple cultures and systems over several continents and on high-impact partnerships, and that have undoubtedly required a broad spectrum of expertise in both the hard and soft skills. She serves on the board of advisors for a foundation promoting preparedness for emerging infectious disease in her home country of Nigeria, that project of which we are a partner and how I originally met Dr. Benson, and that's not even in her bio. I'm sure there's a lot that's not in her bio. And I just want to recognize that as a female, transnational, global health leader of color, she is a true inspiration and role model for all of us. Dr. Benson, we are so proud to have you as our keynote speaker. Please.
Thank you very much. And is it good morning, good afternoon already? I was very nervous sitting at the airport in Geneva, and I was thinking nothing had better go wrong. And I was watching, and I was going on my phone, looking at the weather forecast and worried that there might be a snowstorm or something that would delay the flight or cause flight cancellation. But thank God none of that happened. First of all, I just wanted all of us to give a big round of applause to all of the speakers that went before me. Because, you know, I heard passion, I heard compassion, I heard resilience, I heard purpose. And nothing beats that when you're in that journey of global health. So first of all, let's just give a round of applause to all of the speakers that went before me. In fact, I think that they have made my job very easy because they've said a lot of the things that I would have said in my presentation, and which I would. And I'm going to ask you all to please permit me to speak from the heart, because I don't know how else to do this otherwise, other than to speak from the heart. I want to start with a story. And it dates back to my native Nigeria, and I was a physician practicing. I was in private practice at the time. And they brought in this young girl. She must have been about maybe 4 or 5 years old. I'm not exaggerating, but there were worms coming out of every orifice you can imagine. Tapeworms. She had a heavy tapeworm infestation, and they were coming out of every orifice. And they brought her into the emergency room. I was on call that night. She was severely dehydrated. She was on the verge of death. And so the first thing was to set up a line. Her veins were collapsed. We were trying to get the surgical team to come in and do a cut down. And I'm watching the clock, and I'm looking at the girl, and she's gasping. And I said, she's not going to make it. Now, there's some things that teach you in medical school, but there's some things that you would never learn in medical school. And I knew that I had to do something. I don't know where it came from, but the next thing I knew, I asked someone to grab me a table. I jumped on top of the table. Before I did that, I looked at the girl, and I saw a pulsating artery on her temporal region. And it was not like I was even thinking, I'm going to do this. But I just said, you know what? In my mind, that split second, I said the only chance of survival is to get this line into an artery. Nobody ever talked to me about putting a line in an artery in medical school. It was, they would cut down, put it in the vein. At least not for this young child at that point in time. I got the needle. stuck it in. Of course, the blood started to back up. And that's when I asked for the table. I jumped up on the table and I held it very high. I asked somebody to get me a pole, and I took the line and I held it up against the ceiling. And then the fluid started to go in, the blood started to back up. And within a few minutes, the girl started to revive. And I thought to myself, this is wonderful, you know, because she survived that tapeworm infestation. But at that point in time, what she needed was fluids. And I was excited to be doing that to save a life, but that was one life. I come back to when I was in medical school. I actually helped establish a foundation called Rubies. All the way back then, I've always felt that individual patient care was great, but there was something else that was nudging me beyond individual patient care that I knew I needed. And I knew there was something that I needed to do that will change the lives of populations, change the life of public health with just a stroke of the pen. But I didn't know what it was. But I knew that there was something else beyond individual patient care. And don't get me wrong, I loved individual patient care. And even if I say so, I think I was a pretty darn good doctor. I mean, I had bedside manners. But there was just something that kept nudging me, that kept pushing me, and I couldn't tell what it was. Fast forward a few years in private practice. I don't know where it came from, but I knew I wanted to go work with the World Health Organization. And it was a calling. It was a sense of purpose. And I remember telling my parents, I said, you know, I want to go work in public health. They didn't get it. I mean, they're like, we spent all this money for you to go to medical school. What are you talking about? And I'm like, yeah, you know what? We'll do this and many more people's lives can be saved. But they didn't understand, and I personally didn't even understand what I was getting into. So some of you here are actually asking yourselves, why am I even here? Why am I in a medical program? Why am I studying to be a doctor? And maybe you already have it figured out. I'm happy for you. But for those of you who are questioning, why am I in this medical program? Why am I in this MPH program? Why am I doing a PhD or whatever it is that you are doing at this point in time? Some of you are also asking yourselves, and if I do all this, then what? And how do I get there? What's the road to getting me there? And who can help me get there? And those are some of the questions that you're all asking yourselves. I asked myself some of these questions, but I don't think I really spent any time trying to find out what the answers were. It was just in my subconscious. So today, I'm going to tell you a little bit about my journey, my aspirations. What was it that I wanted to do? And how did I get there? And what does that mean for you? And I think I shared some of this in the intro when I said I started out my life in Nigeria. I'd love to tell you that I came from an impoverished family. I'll be lying to you. No, I didn't have that. That was not my experience. I think I came from a pretty privileged home. I enjoyed all of the privileges that I'm enjoying here in the United States. But that didn't mean that I was blind to what was going on around me. I could see it. And there was a part of me that just had that sense that I could not stand any form of injustice. And not having proper health care, not having access to health care is an injustice, whichever way you look at it. So for me, even though I didn't have that experience, I could not ignore what I was seeing around me. And there was something in me propelling me to do more. So that was my experience in Nigeria. Then I got married, and my husband is living in the United States, and it's like, okay, what do I do? And now I need to move. But there were several things that were pushing and pulling. So on the Nigeria side, I had my extended family. My parents were there. My sisters were there. I had some members of my family in the United States. But I had this pull. I wanted to stay back. I wanted to make a difference. And I felt that if I left, I would have a sense of loss. But then I have a husband. And now I'm expecting our first child. And so there's the immediate family pull as well. So the pushes and pulls were there. And what to do? But obviously, as you can tell, my immediate family won over. And as I mentioned to you before, that at the back of my mind, there was something that said, you need to go work at the World Health Organization. You need to establish a career in public health. And that's where I wanted to be. So that was my aspiration. And how did I get there? And as the gentleman said previously from NCI, he says, it's not a straight road. It's really more like a zigzag. You can't even describe what it was. And so I started on that journey. And my first port of call was New Haven, Connecticut. My husband was at Yale, New Haven. He's also a physician working in emergency medicine, and he was doing a program in preventive medicine and public health. So we were there for a couple of years, and I started a family. My first child was born, so I was a stay-at-home mom. But I knew that that was just going to be for a while. And then I decided to apply to both Yale and Harvard. And at the time, people said, you're crazy. You're not going to get in. And I was like, okay, well, if I don't get in, I don't get in. That's it. So no big deal. I applied. Both Yale and Harvard accepted me for a program in public health. I chose to go to Boston. And so off I went. At that time, my husband had finished his program at Yale, and he was working. So we were kind of shuttling back and forth between Boston and New Haven. Finished my program at Boston. And I tell you, there were days when I walked up that hill back to my apartment and I thought, what am I doing? It's freezing cold here. It's snowing heavily. I must be insane. And at this time, I was expecting our second child. And so it was even much more difficult. But I navigated it, finished the program, and went back to Connecticut. I started working at the public health department in Stamford, Connecticut, working on the HIV/AIDS program, and also the school health program. And I was spearheading both programs. Did that for a while, and then my husband decided that he'd had enough of emergency medicine and he wanted to go do something else. He was approached by a recruiter who said, you know what, we need people like you in the pharmaceutical industry. And at that time, neither of us had any inkling as to what physicians would be doing in the pharmaceutical industry. Cut a long story short, he decided to give it a try. So he was appointed head of the clinical and regulatory department, and he moved to Philadelphia because he was working with Merck. So I obviously moved along with him. I left my job at the health department. I came to Philadelphia, and I thought, I'll go work with the health department. And I had a couple of informational interviews, as you mentioned. And the gentleman said, well, you know you're going to have to live in the city. Now, when I saw the surroundings of the health department, I said, hell no. I'm not a city girl. I'm a country girl. This is not happening. And I'm not raising my kids in the city. So I opted to not do that. And then my husband said, well, why don't you go talk to a couple of people at Merck? Come talk to them and see, if there are any opportunities for you. Was not involved in research. And everybody thought, you're crazy. They're not going to hire you to go do a research job. Now, I'm sharing all of these steps with you because whatever you're doing now, you might think, this has no bearing on where I want to go. But I'm telling you, you never know how all the dots will be connected. It's only now, standing where I am, looking back, that I realize, I see how all the dots were connected to bring me to where I am today. Nothing, I'm telling you, nothing could have prepared me for what I'm doing today. But as I look back to all of my education and my experiences, I realize that they were all preparing me for this moment. So I go to Merck, and what I thought was an informational interview, I met with about 3 or 4 people. I was in heels. The head of department in a research department took me on a walk. It was during the lunch break, and my feet were killing me. But she was intent on doing this walk around, and we talked. And finally, I just forgot all about it. I went back home. About 2 weeks later, I get a call. And it was from the HR, and they said, oh, we're calling to offer you a position in the research area, and you're going to be working on, our HIV drugs. And I just laughed to myself, like, oh, you don't know, no, not me. I mean, I didn't say that out loud, but that's what I was thinking. And she said, what pay structure are you looking for? So I said, no, there's got to be a mistake. I did not interview. My husband is in the background, and he's hearing me, and he's like, no. And so he said, because I said, hold on. I put the phone on mute, and I said, what is it? So they're offering you a job. Are you crazy? Just say yes. So I come back on the line, and I said, yes, or I accept, blah, blah, blah. And then the rest is history. I joined Merck. And that's how I got to Merck. But my goal, and that's I started talking about Merck, and this was in the safety and epidemiology area, and I was assigned to do the epi work on our HIV/AIDS product, which is Crixivan, a protease inhibitor. And this was in the era where HIV/AIDS was really at its peak. It was at its height. And people were selling their insurance schemes, believing that they were not going to make it. And that was what I was hired to do. And of course, so I started reading everything and every article that I could find just to make sure that I was on top of my game. 5 years into that work with on HIV/AIDS, and that gave me exposure to the AIDS community, gave me exposure to the NGO community that was already advocating for lower HIV/AIDS drugs. And I would never forget, we were at Durban at the International AIDS Conference where the AIDS activists were picketing, and it was my first foray into this world of the NGO AIDS activist world. And I learned a lot. I learned a lot. 5.5 years into this, I'm minding my own business. The executive vice president of our clinical and regulatory development said, Joan, didn't you say that you were from Nigeria? I said, yeah, I am from Nigeria. She said, you know what? We're thinking of this thing with the Bill and Melinda Gates Foundation, and we need someone who has sensitivity to the African continent. Are you interested? I said, oh, yeah, sure, I can do it. And because that was my mindset, I can do anything. You just tell me what it is, I'll figure out how to get it done. Even if I know nothing about it, I just felt I'll figure it out. So I said, oh, sure. So she asked me to go talk to a couple of people. I went, and then they offered me the job. I had no idea what I was going to be doing, but they just said, this is a partnership. Merck had decided to offer $50 million to address HIV/AIDS in Botswana. And again, this was at the height of HIV/AIDS in Botswana, where the prevalence of HIV was about 40%, and that's an underestimate. And when we visited, myself and a team of people from Merck visited, every other bed in that hospital in Gaborone that we visited was occupied by an AIDS patient. It was devastating. We went on home visits. It was devastating. But this was a partnership that we had forged with the Gates Foundation to address HIV/AIDS in Botswana with the government of Botswana. And so we started that program. And I was co-leading with another colleague. A few months into the program, I said, you know what? Wouldn't it be great if we could get a mentorship program going, kind of a twinning program where we would bring people from hospitals in the developed world to work alongside physicians in the developing world, like Botswana, so that they can learn from each other. The Botswana physician will learn about, advanced care for people living with HIV, or at that time it was dying of AIDS. And the person from the developed world will learn about the clinical presentation of HIV/AIDS in the developing world, because we were seeing things that were slightly different than what was being seen in the developed world. And the progression from HIV to AIDS was very rapid. And from the diagnosis of AIDS to death was even more accelerated. So I thought it would be a great twinning program. And my mind, because I was in the Philadelphia area, my mind went to Penn. I got in touch with, and I think he's retired now, Harvey Friedman. He's still here. Well, so I heard that he was, head of the infectious diseases program at the time, and so I called him up. Never met him before, and I told him my idea, and I said, I'd like to come talk to you. I came in, we chatted for about 30 minutes, and then he says, sounds interesting, but would need to run this by the board. So he says, can you come and talk to our board of directors and such and such a date? I said, sure. I had no idea what I was doing at the time. But anyway, cut a long story short, put on my shoes, I came and got into the room, I think there were about 5 of them, 5 elderly Caucasian male. So I'm sitting there, I'm not even thinking, I don't have any slides, nothing prepared, but I had it in my head. I had the vision of what I wanted to see happen in Botswana. I had that vision in my head. And I shared with them what was in my head. And they looked at me and they said, sounds interesting. Let's give it some thought. We'll come back to you. A week later, Harvey calls me and says, we're in. And the idea then was that Penn will send a couple of physicians. Merck would pay for those physicians, and they would go to Gaborone and work in Gaborone Hospital. But then that was just, 1 or 2 physicians every year, and they would do a rotation, and that was 3 months or 6 months. And that was the thinking. But then it's not scalable. But at least I felt I had gotten something going. And then there were a couple of other hospitals from the UK and from the Netherlands that also, came on board and decided that they wanted into this thing. But fast forward, Penn just took it and ran with it. And that's what we have with Penn, became Penn Botswana, I think is what it's called now, with Dr. Exactly, and with Dr. Doreen, whom I'd met a number of times in Botswana, and I don't know if she's still on. But hats off to Penn for catching the vision and just running with it. So that was another partnership. So I did that a couple of years, and that was my commitment, to work on this initiative for 2 years, get it up and running, and then we'd turn it over to the government of Botswana. And then I'll move on to whatever else it was that I was being called to do. 2 years into this, and when I was thinking about what next, because my agreement with the research side was that I'll do this for 2.5 years, and I'll come back to the research side. Walking down the hallway, Dr. Adil Mahmoud, late Dr. Adil Mahmoud, who's gone on to blessed memory, who was president of Merck Vaccines, saw me and said, what are you doing, Dr. Benson? Are you staying out of trouble? That's how he always greets me. Are you staying out of trouble? I said, you know, I try, but I never succeed. And he said, and I told him, I said, well, I'm going to go back to research. And he said, what are you going to do such a stupid thing for? And I said, well, because that's the arrangement. He says, no, we need you in vaccines. We need you so we have a medical affairs team there, but there's no one dealing with adult vaccines, and we need you there. So that's how I got to working in vaccines. Again, I did not apply for the job. So just as somebody else, one of the other speakers was saying, don't always think that, you know, if I check this box, check that box, and the other box, that I would be ready, just ready for that next role, and they would see how wonderful I am. My philosophy is that do the best darn job you can wherever you're at and enjoy doing it. I mean, it sounds crazy, right? But sometimes that's what it takes. Because you're thinking it is your expertise or your skills that people are looking for. Yes, it is. But sometimes those softer skills that people can never teach someone. I can't teach you to be passionate. I can't teach you to have compassion for people. I can't teach you, well, maybe I can, resilience. But there's some things that nobody is going to teach you. It's going to come from within you. And so for me, my philosophy is I do the best darn job wherever I'm at, and somebody's going to find me. It may not always work out that way. So please, this was just I'm sharing with you my story. Doesn't mean that my story works for everyone, right? Because there's sometimes you're going to have to put yourself out there and sell yourself. But for me, that was not my experience. And sometimes it's a combination of things that gets you to that next step. And these things that I'm sharing with you are things that are applicable not just in the global public health space, in anything that you do. So I just did the best darn job I knew how to in medical affairs. And then my predecessor in my current job retired, and I was asked to lead a public health partnerships effort. And why am I sharing this? Because remember, my aspiration when I started out in Nigeria was to get into public health. I wanted to work with WHO. So I started to ask, what is this public health partnerships job all about? Guess what? It was for me to lead our partnership efforts. You guessed it right, the World Health Organization. And not just the World Health Organization, the Gavi Alliance that pays for vaccines for the developing world. To lead our partnership and engagement with the Bill and Melinda Gates Foundation, UNICEF, the UN agencies, and any other global health organization. So I got much more than I even asked for or ever wanted. And that is how I got to where I am. That's why I call it my non-traditional journey into public health. But it started with an aspiration. It started with a desire. And all of those, so this is just to show you that all of those organizations, UN organizations, are all interconnected. So even though I wanted to work with WHO, but there are part of an alliance of organizations that are involved in this vaccines ecosystem. So what keeps me up at night? I'm going to talk about a couple of things. Cervical cancer, and I heard my colleague here talk about cervical cancer, which is the second most common diagnosed cancer in the developing world and the third leading cause of cancer-related deaths in developing countries. And you can see where the dark blue and the almost sort of light blue are where there is the greatest concentration of the burden of disease. The mortality is high in these low-income countries. And 70% of these cancers can actually be prevented with a vaccine. I mentioned earlier on the rate of the death, prevalence of death, that majority of them, of the deaths that occur in the developing countries. And this is it really astounded me that every 2 minutes a woman dies of cervical cancer. So you can do the math while we've been here, how many women have died. But this is what really keeps me up at night. When you look at where, so the top, which would be your left, right, is the
yeah, your left. The global distribution of cervical cancer incidence, and you can see those dark blue areas where they're highly prevalent. If you look at screening, and this is HPV DNA screening, more advanced technology, you can see that there's hardly any going on where the greatest burden is. And then when you look at the HPV vaccine introduction, they're not in those places where the burden is. This is what keeps me up. And I just show this just to make the point that if the green is the total female population that could be eligible for vaccination, and you look at the blue, that little blue hot spot there, that's the female population in countries with the national HPV vaccination programs. But look to your left-hand side where I orient you to the less developed nations. It's just a blip when you talk about people who are really having access. So we've got a big access issue here, where the people who need them are not getting them. But we're playing our part. I'm playing my part. And there are many different challenges, and I'm not going to go into all of them, but advocacy, how do we get governments, how do we get leaders, country leaders, world leaders to pay attention to this issue? Political will, there's a political will and commitment. Where is the money going to come from? Innovation, there are new innovations coming up in the developing world. I mean, we all here in the developed world, we take some things for granted. I can go to my doctor's office, right, and get a pap smear, and I do this annually. But that's not their story. They have what they call visual inspection with acetic acid. That's a very basic form of identifying a diseased cervix. And then program implementation. You have the interventions, but can you actually get them to people who need them? So a number of things that we've been doing, right? The Gardasil access program, this was something that we decided to do before Gavi started paying for the vaccines for low-income countries. And we implemented small-scale programs just to demonstrate the feasibility and the acceptability of this vaccine, because what we were told by global entities is that, oh no, and we heard the same story with HIV. They're not going to be able to do this. It's going to be too complicated because we're talking about, teenagers who are not in care. They're not in the clinics. So how do we get this to them? And it was a whole same story about HIV. You know what? There are too many medications. They have to take them at scheduled times, and they don't have watches and they don't have clocks, and they're not going to be able to do this. This was the first. This was one of those partnerships. We did this in Bhutan. And it was a partnership with the Australian Cervical Cancer Foundation and Merck, and it was a 6-year partnership to vaccinate girls. Some other partnerships, there are various vaccination programs, and I think this is just a test in your geography of the African continent and also your knowledge of the flags. The first one is Uganda, the second one is Tanzania, Rwanda, and then the third one, Tanzania, and the fourth, Zambia. And these are just some countries where we have worked very closely in partnership with the government to roll out HPV vaccination to address the scourge of cervical cancer. On the left-hand side here is the Drc Ebola outbreak, and I was excited, but pained somewhat when I to hear about the recent outbreak in the DRC. But I mentioned it here because we have a vaccine against Ebola, and that's being used in the current outbreak. And as horrible as that outbreak is in the DRC, we also recognize that without this vaccine, that outbreak would have been much worse than it has been thus far. So, and that's why I just came out from a meeting with the WHO, the World Health Organization in Geneva, to talk about the role of the vaccine in pregnant and lactating women and whether or not it can be used in infancy. These are just some of the other vaccination partnerships to facilitate access in Peru, India, specifically in the state of Punjab and Haiti. And again, there's so many, but I just called out a few of them that we have been engaged with. In Haiti, it was with Partners in Health, actually, that we did that, Zamila Sante. And so these are all things that we're very proud of. They're helping bring interventions to places where ordinarily they just would not have had access. And we must leverage this increased global momentum. It was Tedros who said, if we do not act today, that the deaths from cervical cancer will rise by almost 50% by 2040. So in the final analysis, a career in global health came through a different channel for me. It was different channels. From my aspiration, the journey was not a direct one, but finally I got where I wanted to go, and even much more. I thought I'd take a moment and just tell you about a collaboration. I'm not directly involved. I'm not leading this one, but I'm indirectly involved because we're trying to see how we can actually leverage this collaboration, this initiative that Merck has embarked on, which is to address maternal mortality in developing countries. And the figures are outstanding. Every day, 800 women die from complications of pregnancy and childbirth. It's really outstanding. To me, this is just unacceptable. And so, we have decided that this is what we're going to do. We're going to put our money, behind this. So we've committed $500 million to over a 10-year period to address maternal mortality in developing countries. And what I'm now doing is working with the person who leads this initiative to figure out how we can leverage what we're already doing, the capacity that we're building in these resource-limited settings for maternal mortality. How can we leverage them for cervical cancer? Because it's the same woman. It's the same woman. So we save her from dying during childbirth, but we lose her to cancer. That just does not make any sense. So finally, what have I learned? Don't let anyone tell you that it can't be done. That's what I have learned. There's so many things that when I first started talking about the fact that cervical cancer can be eliminated, even within my organization, people laughed. They said, Joan, here you come again. I said, you know what? It's going to happen. You just wait and see. It's going to happen. People are going to start talking about it. And 5 years later, the Director General of WHO stood up and has given a global call to action to eliminate cervical cancer. Don't let anyone tell you it can't be done. Whatever it is that your mind is telling you, whatever it is that you have envisioned can be done, it can be done. It's just, it might take time. And global health it's not a sprint, it's a marathon. It takes time, and you've got to be patient. So first of all, and surrounding that are the things that I have learned. Faith. I'm telling you that my faith, I believe that my faith in God, and knowing that I had a calling for something. It had gone beyond, for me, it had gone beyond a job. Yes, it was great that I had a job. I'm thankful that I have a job that pays the bills, but for me, it's a calling. And if you have that thrust, that thing that's telling you you need more, just follow it. Family. I always tell my direct reports, I tell them family first. If your family is unhappy, your traipsing around the world is only going to give you temporary joy because you're going to come back and meet an unhappy family. Make your family happy first. Compassion, we talked about our passion. Kindness. Because you know what? The global health community is a very small-knit community. You're going to meet people along the way. You will go away. You go do something else. But it's such a small, close-knit family that you will come back and meet them. Be kind to people along the way. Whether you feel that you can help them or they can help you or not, be kind. Connectedness, we're all connected one way or the other. I was, when she was talking about, Ebola, we didn't plan any of our presentations. I had no idea she was going to be talking about Ebola. I had no idea you were going to be talking about cervical cancer. I had no idea, where's the speaker who talked about Mectizan donation program? I had no idea that she was going to be talking about Mectizan. We manufacture Mectizan, and our company actually made a decision in 1987 to donate Mectizan everywhere, wherever it's needed. And we donate about 300 million tablets a year, and we've donated over 2.7 billion to date. And it takes only one tablet annually to protect someone from guinea worm, blindness, and lymphatic filariasis. One tablet every year. Hard work. The times I don't get enough sleep, but I try to make it up, but it's hard work. Don't let anybody tell you otherwise. You need people. You can't do it without people. You need to talk to people. Got to find out the hearts of the people who are in the communities. You cannot do global health just sitting behind your desk. Yes, you may come back and do that, but you got to see and know the heart of the people. And the solutions come from the people. They know what they need. And so talking to the people, hearing the hearts of the people is critically important to get into solutions that work. Because if you create solutions in the developed world and you try to spring it down on them, I tell you it will fail, because they will do everything possible to sabotage it. It doesn't work. The possibilities are endless. If you can imagine them, they're there. And we've already talked about resilience. You'll fail some. I failed sometimes. When I told you about cervical cancer a few years ago, when I first started talking about elimination, nobody wanted to hear it. I thought I had failed. But I said, you know, one day somebody's going to recognize what I'm saying. And I put my presentation, I put it on the back burner, and I said, I'll dust it up one of these fine days. And I dusted it up again. And so now as a company, we are trying to figure out what we need to do as a company to stand behind cervical cancer and the elimination of it. And I think that's the last of my slides. So I just want to end on that note and just say that the possibilities are endless. If you can think it, if you can dream it, you can do it.